Hello everyone, and today we are going to discuss about ameloblastoma, often described as benign but aggressive odontogenic tumor. It is a benign but because it does not metastasize, okay? But aggressive because it invades local bone extensively. The bone we are talking about is the jaw bones, our maxilla or mandible. So keywords you should immediately associate with ameloblastoma are locally invasive, multi-ocular, and the classic soap bubble appearance on radiograph. So this topic is high yield for both your oral path and oral surgery. Now, moving forward, we will see why this matters. So, ameloblastoma is the most common clinically significant odontogenic tumor. Clinically, the problem is not pain, the problem is delay in diagnosis. If left untreated, it can lead to severe facial deformity and loss of jaw continuity. So, for this reason, from an exam point of view, it is frequently tested in your MCQs, Viva examination, and OSCE the case discussion. So this is a tumor you are expected to recognize instantly. Now we're coming to the definition of ameloblastoma. So ameloblastoma is defined as a benign but locally aggressive epithelial tumor of odontogenic origin. So I will put some, highlight on this. Its region is odontogenic, an epithelial tumor it is. It grows slowly, which often gives a false sense of safety. Okay. However, if it is not treated radically, it has a high rate of recurrence. You have to consider it. This single line explains why conservative treatment usually fails in this case. Now we will move towards the etiology of ameloblastoma. Ameloblastoma originates from odontogenic epithelium, as I have told you. The most common source is remnants of the dental lamina, also called resto series. Other possible sources include reduced enamel epithelium, basal cells of oral mucosa. At the molecule level, BRAF V600E mutation are frequently identified since it is a benign, tumor. Importantly, there is no proven link with trauma or infection. In this case, most cases arises without any obvious trigger. Now we will move towards the pathophysiology. The disease process begins with a genetic mutation in odontogenic epithelial cell. Okay, so a genetic mutation occurs in our normal cells that are odontogenic epithelial cells. These cells then undergo uncontrolled proliferation, forming cells that resembles ameloblast. As the tumor grows, it invades bone marrow spaces rather than pushing bone away. This causes progressive bone resorption, expansion of the jaw cortex. If untreated, the tumor can perforate the cortical bone and extend into the soft tissues. Now I will show you how clinical features looks like in ameloblastoma. So the clinical features includes ameloblastoma most commonly presents between 30 and 50 years of age, but it can occur at any age. About 80% of cases occur in the mandible, particularly in the molar ramus region. You can see that it is occurring at the molar ramus region. Clinically, it is a slow growing, painless, faint to hard in consistency. In advanced cases, you may feel eggshell cracking, displacement, or loosening of tooth. Pain is usually absent until late stages. So we have to know what is the difference between us initiation of the stage and the advanced cases. Now moving to the diagnosis and key finding. Radiographically, ameloblastoma has a characteristic appearance like the classic pattern is multi-ocular radiolucency, as I have told you, described as a soap bubble or honeycomb. You have to understand these two terms and learn them in the case of ameloblastoma. In younger patients, especially in the unicystic variant, it may appear unilocular. A key diagnostic feature is knife edge root resorption of the adjacent lead. I will again repeat, a knife edge root resorption of the adjacent lead. Histologically, the follicular type show epithelial islands with peripheral palisading, and the I have to I just forgot to told it has two types, the follicular type and the plexiform type. Now coming to the plexiform type, shows interconnecting cords in a net-like pattern. These findings confirm the diagnosis. So this was its histopath and radiology. Now we will come on the management and treatment of ameloblastoma. Management of ameloblastoma must be planned carefully. First, biopsy is essential. Radiographs alone are unreliable, and misdiagnosis leads to undertreatment. Once confirmed, CT or MRI, CT scan or MRI is used to assess true tumor extent and bone margins. Definitive treatment is wide surgical excision with 1 to 1.5 centimeters of clear bone margins. Simple curettage or enucleation is inadequate and lead to recurrence. So we have to go for a wide surgical excision. After resection, reconstruction may be done using we can use bone grafts, titanium plates, or vascularized flaps in extensive cases. Finally, long-term follow-up is mandatory for at least 10 years because recurrence can occur late. So this was our management and treatment of ameloblastoma. Now, thank you for the focus and all. If you have any questions, you can ask us on our in the comments, and please kindly subscribe so we can keep uploading and keep making it easier for you. Just closing takeaway line is ameloblastoma is benign in name, but it behaves aggressively and it must be treated with the same respect as a metastatic or a tumor. So you have to understand it. Thank you very much, and keep subscribing and keep updated by putting the bell icon by pushing the bell icon. Thank you.